USMLE-style question. HIV-associated dementia. A 46-year-old man with a history of HIV/AIDS presents to the clinic with progressive memory impairment, personality changes, and difficulty concentrating over the past several months. He also reports apathy, slow thinking, and difficulty with problem solving. His CD4 count is 95 cells per microliter, and viral load is high. Neurologic examination reveals bradykinesia, impaired attention, and hyperreflexia, but no focal deficits. MRI of the brain shows diffuse cerebral atrophy with increased signal in the basal ganglia and deep white matter on T2 weighted imaging. Which of the following is the most likely pathophysiologic mechanism of this patient's condition? A. Autoimmune-mediated demyelination of CNS white matter. B. Direct HIV infection of macrophages and microglia, leading to neurotoxicity. C. Reactivation of JC virus causing demyelination of oligodendrocytes. D. Vascular endothelial dysfunction causing multiple small infarcts. E. Beta amyloid plaque deposition and neurofibrillary tangles. Answer and explanation. Correct answer. B. Direct HIV infection of macrophages and microglia, leading to neurotoxicity. This patient has HIV-associated dementia, a late-stage neurocognitive disorder seen in advanced HIV/AIDS, CD4 200 cells per microliter. Key features of HIV-associated dementia: gradual cognitive decline, memory loss, executive dysfunction, attention deficits, behavioral changes, apathy, depression, personality changes, motor symptoms, bradykinesia, hyperreflexia, gait instability, MRI findings, diffuse cortical and subcortical atrophy, white matter hyperintensities, particularly in the basal ganglia and deep white matter. Pathophysiology: HIV infects macrophages and microglia in the CNS. Infected cells release neurotoxic cytokines, TNF-alpha, IL-1, neuronal damage and atrophy, white matter involvement, subcortical dementia, slowed processing, executive dysfunction, motor deficits. Incorrect answers: autoimmune-mediated demyelination of CNS white matter, describes multiple sclerosis, MS, which presents with relapsing remitting sensory motor symptoms, not progressive dementia in an immunocompromised patient. C. Reactivation of JC virus causing demyelination of oligodendrocytes, seen in progressive multifocal leukoencephalopathy, PML, which presents with rapidly progressive focal neurologic deficits, hemiparesis, ataxia, vision loss, rather than dementia. D. Vascular endothelial dysfunction causing multiple small infarcts, describes vascular dementia, which presents with stepwise cognitive decline and focal deficits, not the diffuse atrophy seen in HIV. E. Beta amyloid plaque deposition and neurofibrillary tangles, seen in Alzheimer's disease, which presents with early memory loss and hippocampal atrophy, not executive dysfunction and bradykinesia. Key learning points: HIV-associated dementia, seen in advanced HIV/AIDS, CD4 200 cells born of dementia, slowed thinking, executive dysfunction, behavioral changes, motor symptoms, bradykinesia, hyperreflexia, gait instability, MRI, diffuse atrophy, plus white matter hyperintensities in basal ganglia. Pathophysiology: HIV infects macrophages, microglia, neurotoxic cytokine release, neuronal damage. Would you like a question on PML versus HIV dementia?